disease, and then followed by a lot of other ones. More recently, as we've approached school, we have been testing more children. And so you've probably seen some of these headlines coming out in the past few months. And this was just last week in Time, and it was confirmed coronavirus in US kids rose by 90% in 4 weeks this summer, and the total is close to 400,000. And then there was just a headline yesterday that talked about an increase of 17% in kids over 2 weeks. It's important to look, though, at where this data comes from. So this is a study from the AAP and the Children's Hospital Association, and they are releasing data about every 2 weeks looking at case rates in kids. So overall, the case rate for COVID in kids under, most of these states are under 20, is what they're counting, is about 631 per 100,000. That's predominantly driven, you can see, by a lot of southern states where they're experiencing a significant surge in disease. And it's important to realize that Maine is way down here at the bottom with our case rates in kids. And we are actually testing a lot of kids here in Maine. So the only state with lower case rates than us is Vermont. So overall, similar to national data, kids account for about 10% of our total cases, but our rate is a lot lower than that 631 per 100,000 reported nationally. Our rate is closer to 160 per 100,000. It is important to note, though, that this rate is going up. Last week, it was about 147 per 100,000. So some of that is more testing, some of that is probably reopening and people being more involved in activities. But overall, it speaks to the fact that even with these national surges, if anywhere can do this and do this successfully, it probably is going to be Maine. The other question we have to think about is how likely kids are to transmit the virus to others. If we're thinking that most kids aren't getting really, really sick, and that we have really low rates in Maine, we do have to think about how likely these kids are to bring the virus home or to transmit it to teachers or other immune suppressed staff. So the first thing we look at is viral load. And there have been at least 3 studies published looking at viral load in kids. And what I want you to focus on is this line graph over here. So when you look at kids 0 to 11, adolescents 12 to 19, young adults, and I love that they put up to 45 in young adults, and then older adults, 46 and up, then really the amount of viral load detected by PCR is similar across age groups. But the caveat is that this was just looking at viral load, and we know that viral load does not necessarily equal infectivity. We know that kids don't get as sick with this, they're not as symptomatic with this, and so maybe they don't spread it as well. So then we look at studies that look at transmission rates, and this was one of the first fairly good studies that was published about this, and it was from South Korea. And so basically they broke folks up into 10-year age brackets, and they looked at their household and their non-household contacts, and they looked at the percent infected. So when we look at the 10 to 19, the adolescent, high school, middle school age range, for household contacts, there were 231 contacts, 43 of them became infected for a transmission rate of 20%. The non-household contacts, it was less than 1%. And this was very similar to the older age range. The 0 to 9-year-olds, however, their rates of transmission were much lower at 5% and 1%. So this was reason for cautious optimism. It's important to note, however, that schools were not in session, so especially the 0 to 9-year-old age range did not have the number of social contacts they normally do. So there's a lot of unknowns still about how well these kids are going to transmit the virus when they're out and about. And this was another study from Italy. It's much, much smaller, but it gives me a pause, because when they look at the 0 to 14-year-old age range, they had 14 cases. Those 14 cases had 49 contacts. Again, schools were not in session, and they had an attack rate in this age group of 22%. And then they looked at these secondary cases, these 11 cases that were contacts of the original cases, and 8 of those 11 infected others. And of those 8, 3 of them were under 5 years of age, and then 4 of them were 5 to 10 years of age. So I think the data is still really, really unclear about how well young children in particular transmit this virus. But we do have some lessons learned here when we open schools. So we know that kids can become ill with COVID, but they're less likely to be severely ill than adults. And it's important for our patients to look at individual risk factors when they're determining their individual school decisions. We know that community rates play a role in the number of kids infected, but states like Maine with lower rates have a greater chance of success with school. But the caveat to that is we have to keep our rates low. We think that kids may not transmit as much, especially young kids, but it's really, really unclear how that's going to play out with increasing social contacts in schools and sports and everything else reopening. So it's important for households to look at their risk factors. Overall, I think all of us would agree that schools provide an essential service and we need to open them, but we need to do it safely. And that brings us to non-pharmaceutical interventions in schools, which I'm not going to talk about too much, but basically it's social distancing, 3 to 6 feet. wearing face coverings. This was an MMWR study that looked at 2 symptomatic hairdressers who were wearing face coverings. All their clients were wearing face coverings, and there was absolutely no transmission throughout, despite being exposed to almost 150 clients. And then, of course, washing your hands, that kind of goes without saying. So to talk about those more within our schools, Laura Blaisdell is gonna take over.
Thank you, Jenny. And I welcome people to put questions in the chat box, and we will answer them as we go along. So Jenny talks, a lot about these non-pharmaceutical interventions, and so I'm going to talk a little bit about what the Department of Education and the CDC has put forward in terms of these interventions in school, in terms of requirements and suggestions, and then talk a little bit about resources that are available to pediatricians from the AAP, DOE, CDC collaborations. So we know that if you haven't had a chance to look at the DOE guidance, it provides a framework for options, ideas, and considerations for organizing the work of reintegrating back into person. In general, it's not intended to be used as requirements and mandates, although there are 6 required interventions that the DOE has put forward, and we will get into them. So the main DOE is using a stoplight system for county level risk of spread to determine whether or not schools can consider reopening. And I think Dr. Shaw said it best, that green does not mean screech, go forward. Green means proceed with caution. And at this point, all counties are green, although I think that those are being reassessed currently. And then we will talk about these layers of public health mitigation that have been put forward. So the stoplight system started in January 31st, and it's being updated every 2 weeks. These recommendations are advisory, they're not mandates. And given the large and varied nature of counties in Maine, the independent school districts within a county are welcome to adopt a reopening policy that differs from this county-based categorization of COVID risk. To be clear, that neither the DHHS or Maine CDC would review state plans. So if a school is categorized as green, it suggests that the county has relatively low COVID rates, and that in-person instruction can be adopted. So just yesterday, here is the green for all of the counties, including Cumberland, you can see here. And this is the website if you are interested in looking at how schools are tracking each week. As we talk about public health measures, I think it's important to stop and think about how public health works. So in medicine, oftentimes we know that there's one treatment. Somebody has strep, and so we give them antibiotics, and that goes away. In public health, and particularly in communicable disease spread, it's not just one layer that prevents communicable disease spread. It's the layering on top of each other. And many of us have talked about the Swiss cheese model, that every layer has limitations and downsides to it, but it's the layering of the Swiss cheese slices that closes up those holes and possible weaknesses in each layer. So when we think about opening schools and public health measures, I've been asked, well, what do you think is the most important layer? And the answer is all of them that can be practically put into place at any given setting. But we know in schools there are some settings where we have to use some and aren't able to use others. So it's important to use as many as possible in each setting. So one of the layers is symptom screening prior to school. So it's a requirement that all schools, parents and caregivers and staff members must conduct self-checks of their symptoms prior to boarding buses and entering school buildings. And many of us who have children in the school system are already doing this. We're getting our morning texts or whichever variety of methods schools are asking us to do these symptom checks. Notably absent from main symptom screening is temperature as a symptom screen. As we look across states, probably 50% of states have temperatures in their school screening or in their screening recommendations for industry, and 50% don't. But given the false positive and false negative rates of testing, Maine decided to not include temperature as a symptom screen. Physical distancing is the next layer. Adults must maintain 6 feet of distance from others when at every extent possible. And this maintaining 3 feet of distance is acceptable between students when combined with other safety measures. So there was a lot of confusion and contention about this 3-foot distance. I think it's important as we look across DOE and DHHS guidance, there is nowhere else in our communities that 3 feet has been recommended. And it's only recommended in schools because children oftentimes are sitting sedentary and they're going to be using other safety requirements in addition to physical distancing. The next layer are face coverings. Certainly something we all in the community, pediatrics, and perhaps at the hospital specialist office as well are hearing a lot from patients about masking. Adults are required to wear a mask or a face covering. The face covering recommendations are not surgical masks like we use in the hospital, but they are double thickness masks that fit tightly over the nose, the cheeks, and the chin. Students age 5 and above are required to wear a mask, a face covering that fits over the nose and mouth. Masks are recommended for children between ages 2 and 4 when developmentally appropriate, and masks must be worn by all students on the bus. The ongoing debate about face shields, as people are interested in not wearing masks or having alternative to wearing masks. There are acceptable situations when face shields can be worn, but I think we all know and say with great deal of caution about making face coverings and face shields equivocal in terms of their ability to prevent risk. We just don't have the data that shows that face shields provide the same level of protection, but hopefully as every page of the day, every day turns a new page on research, hopefully we'll have some information there. Hand hygiene, staff and students must receive training on hand hygiene, and the concept here is kind of a gel in, gel out that we use in the hospital settings of hospital rooms that whenever there's a transition in school, before or after eating, before or after moving a face mask, using a restroom, use of playgrounds or shared equipment, individuals will be doing a gel in, gel out. There are additional requirements for PPE for school nurses and those in close proximity with students when physical distancing is not possible. And the protection is similar to what we use in the clinic setting: eye protection, a face mask or covering, and individuals that are dealing with potential persons of interest, either students who have fevers. School nurses are asked to use a surgical mask and eye coverings. Also out just recently is how the CDC will be responding to positive cases of coronavirus in schools. There's a lot of questions people ask about, well, what if one kid in a classroom has a fever? What if that kid turns into be, she has a contact tracing system and an evaluation, an epi-evaluation system that will look at each case and determine who is at risk, who has been a person of prolonged contact, and give further instruction on that. And then, of course, I'm a big stable cohorts person. That didn't make the top 6, but I try to squeeze it in whenever I can. Small stable cohorts are perhaps the least appreciated of all public health interventions, I believe. This is, the option of using a school as a classroom or a smaller pod of students that remain together over the course of a program. And what this does is not only does it decrease the epidemiologic secondary transmission, but it also allows schools and camps or residential colleges to continue their operations with the other populations that they're serving while they do the isolation and quarantine that's warranted in a small cohort. So if you will do anything for me is talking about small stable cohorts in addition to the other public health measures. As we move on to talk about what DOE has been doing, it's a lot. So Amy and Jenny and I and many others have been sitting on meetings in addition to Amy's Friday calls to talk with school nurses, to talk with school physicians, and to provide tools and guidance for schools as they reopen. The website of maine.gov DOE/COVID, you can find a lot of these tools. But one is, this is the pre-screening tool for school attendance. It's not, we tried to make it non-complicated about just asking if you've had a fever, if you've been sick with any of the common symptoms, whether you've been in close contact with somebody who has had COVID, or whether you've traveled out of the state. So we tried to keep it simple in terms of school screening and telling folks that if you said yes to any of these symptoms, you should call or see your school nurse or your physician. Additionally, Emily Poland has been working with school nurses to create flow charts for if a child feels or appears unwell. We know that not all schools have a school nurse on site 24/7, or at least during business hours. So she has created this flow chart about whether or not there's a school nurse and how to further evaluate and move forward when you have an unwell or ill child in school. The main AAP website has a lot of these resources for clinicians. Dr. Jubulis is going to talk about the decision tree that she has helped create for COVID symptoms in the pediatric office. There are return to plays decision trees. There's sample office protocols. There's a lot of information about mass desensitization and exemption decision support and letters, testing and healthcare research, mental health resources, and resources for families. So I welcome you to go to that website. If there's anything that you don't see there or you have something that you'd like to share, please feel free to email myself or Deb Hagler or Dee Carey. So I'm going to let Dr. Jubulis walk us through this chart, which has been so helpful, but is very complicated. Jenny?
All right, so so I agree. This is very complicated, which unfortunately seems to be the mantra for the school year. But this was not created in isolation. So this started. There's been a group meeting through the Pediatric Infectious Disease Society, talking about schools. And there was a group of doctors, Peds ID folks at WashU and St. Louis, who came up with a version of this, and then it's been tweaked to fit various communities around the country. So this is kind of our main version. And so what we have looked at is how we're going to get these kids back in school when they have symptoms of respiratory illness, which we all know that is going to happen throughout the school year through respiratory virus season. And we also think, based on epidemiologic studies, that it's not as likely to be COVID, but could certainly be COVID. So what we've looked at is the frequency of symptoms in kids diagnosed with COVID. And there's not a lot of great data out here. And I think one of the important things to consider is that when in studies that have looked at this data, there's not a lot of constellations of symptoms. So it's not like, headache and runny nose and vomiting all together. It's each one reported individually. So none of these symptoms add up. They all add up to more than 100% of patients. And that makes it really confusing. And this is probably something that's going to get tweaked throughout the school year. So keep an eye on it as we get more information. But basically, we broke things up into lower risk symptoms and higher risk symptoms for being COVID. And so lower risk symptoms are things like new headaches. So not a kid who gets migraines and gets their typical migraine, but something that's newer, out of the ordinary. Myalgias, runny nose and congestion, out of the range of ordinary. Nausea, vomiting, diarrhea. So this again would not be a Crohn's patient who's having a typical Crohn's exacerbation, but something new. Any of these above symptoms that are present beyond the typical symptoms. And then the higher risk symptoms are things like new uncontrolled cough, shortness of breath or difficulty breathing, a new loss of taste or smell, and then fever higher than 100.4 or sore throat. So all of these, if a kid has any of these symptoms, this whole table presupposes that they have no COVID-19 exposure. If they have COVID-19 exposure, they fall into a totally different category. But if they have no known exposure to COVID-19, they have one lower risk symptom, they can return to school or childcare after their symptoms have been improved for 24 hours, and assuming they're still not running a fever. If they have more than two or more lower risk symptoms or one higher risk symptom, then, and this is where things are going to get really tricky, and we fully appreciate that this is going to create a lot of logistic challenges for PEDS offices, but we really are going to probably need to test these kids. And so the easiest part of this tree is if you do a swab and they're positive, then they follow the CDC guidance of they can return to school 10 days after their symptoms started and after being 24 hours afebrile without antipyretics, and their symptoms are improving. And all of these kids are followed by the main CDC, so the main CDC will be able to provide approval. So that's the easy one. If their swab is done, and it's a PCR test and it's negative for COVID, then they can return to school when they're afebrile for 24 hours without antipyretics, their symptoms are improving, and the test has resulted as negative. This is an important caveat down here because there have been kids in other states that have gone to school while awaiting their COVID test, and then suddenly the COVID test turns positive and you have a whole class that's exposed. So make sure when you're testing kids that you counsel families that they have to wait for this result, even if everything else is better. If they're seen by a clinician and for some reason there's no swab done, and I anticipate at least at the start of respiratory virus season, this will not be as likely. But if for some reason you feel very confident that it's something else, then again, they can return when they're afebrile for 24 hours without symptoms. And I think I just lost the slide. And then the last category is if things like if somebody refuses a test, basically, and then we kind of have to operate as if they are COVID positive and they are out for 10 days, 24 hours, but the CDC is not notified of those cases.
Sure if we lost Laura, but Jen, if you can hear me, I took over the screen share. So just to let folks know that the AAP has been working with different organizations across the state. They have a lot of different PSAs and social media posts, and one of them is all about me, really to encourage people to take on the community responsibility of working together to open schools. So one is making sure everyone's up to date on their immunizations, making sure that everyone understands the school district's return to classroom policies, and the layering of public health. So proper hand washing, hand sanitizer, mask wearing, and physical distancing. We're really trying to encourage people to stay home if they're sick so they don't risk infecting others, which we know is always a challenge with working families. But we're getting a lot of questions about the algorithm. What if they have one symptom or two symptoms? The reality is if someone's not feeling well, they really should not be going to school, and they should be staying home. So this material is on the AAP website. And then in terms of the main chapter of the AAP conference, so the main AAP has been doing town halls monthly over the last couple of months. And one of the focuses has been on school reopening. The conference coming up for the main AAP, the first day is going to focus on trauma-informed care and ACEs and resiliency and some other topics along the way. I think Carol and Jen are doing a talk on flu. The second day is going to focus on schools because we have to continue to have this conversation Director Shaw from the Maine CDC will be talking, as well as Commissioner Macon from the Department of Education, and there'll be several breakouts on COVID in children and school sports and more. So that conference registration is open. So I'm going to take over now and just talk about some of the programs happening at the state level and policies to support children and families during COVID-19. I know many of you join our biweekly calls and have seen some of this before, but I thought we'd bring it back just to both remind people about what's available, and also I just want to commend and thank all of you for your flexibility, all the work that you've done over the past several months to really make sure that the hospitals are prepared for children with COVID. And we're also, I know you're working hard to get kids into the primary care offices, and you're working with schools, and so we just appreciate all of that. So we'll talk a little bit about immunizations and well visits, some of the policies at DHHS support children, some of the communication tools that are available online that you could use in your practice and in your communities. I know one of the big topics right now is how to get COVID testing for kids, both through schools and in the communities. We'll talk a little bit about that and supporting children with a positive test and supporting providers. So first thing is immunizations. We've really been pushing immunizations since the pandemic started, and knowing that children, to be ready for school, they need to be fully immunized to enter pre-K, and they're required by law to have their vaccinations up to date for both kindergarten and 7th grade. The law around the elimination of the philosophical exemptions goes into place next school year, next September. It's not currently in place for this school year, but still children need to be immunized for school, and they are required to have vaccines for kindergarten and 7th grade. We're also worried, as you all are seeing, about a twindemic, so with COVID and flu coming up in the fall. So we're really trying to push immunizations because many of the vaccine preventable diseases like pertussis and flu can be similar to COVID-19. We did see a drop in our vaccine dose ordering at the state level between March and May. The vaccine ordering dropped about 47%. It's very concerning. We're down about 37,000 doses. And we're also seeing a drop in our primary care visits through MaineCare. So this data is from March to June. You'll see on the yellow line is the children getting their care on the primary care offices, and we saw a significant decrease in those numbers. Here's the vaccine dose ordering data. We're down about 37 doses by the end of May. We've caught up a little bit in June and July, so now our deficit is about 21,000 doses. What happens with the vaccine dose ordering, it's our first indication that rates may be dropping. We've seen an initial decrease in some rates between the 4 to 6-year-olds and our adolescents, but often you're not going to see your rates really drop until 4 to 6 months after the dose ordering happens, because of the way that the vaccine rates are calculated. So we've been asking you, and many of you are doing this, and we're really grateful for that. We're asking primary care provider offices to offer vaccine catch-up and flu clinics. We did a survey in June to see what was happening out there. I think we found that there was at least 17 offices offering curbside vaccines. People were offering additional vaccine clinics, nurse-run clinics during the day, and so we're starting to see the results of those efforts. We're also encouraging providers to increase capacity for well visits, to increase child health preventive services in the next 6 months to get kids caught up who may have missed their well visit during the initial months of the pandemic. Our goals are to try to get to 80%, so 80% on our childhood immunization rates at 24 months, our adolescent vaccines, and our flu vaccines. And for this part, I would say, you know, it's really going to be a capacity issue over the next 4 months to get the flu vaccine out. If we're going to get 80% of our kids immunized between 6 months and 17 years, that's 170,000 flu doses for children and young adults alone, in addition to all the older adults that need to be immunized. So there's a lot of work that needs to be done to get the flu vaccine out. And our next goal is really to try to become neutral on our vaccine dose ordering. So to make sure that the doses that initially were not ordered, the 37,000, we get caught up by the end of the year. And like I said, the last count, we were about 21,000 down, but we are making progress on that. In terms of resources, the Maine Immunizations Program has toolkits on curbside vaccines, a community vaccine toolkit that was just updated, and a school-located vaccine clinic that toolkit that's been put out through the Department of Education and the school nurses. The public health nurses at the state are also offering safety net clinics for vaccines at the different DHHS offices. There's 9 district offices, and those are located on the website. Bangor Public Health is also offering vaccines pretty much on a daily basis to those who call. And so you call either the central number or the Bangor Public Health Nurse to get appointments. The children, when they go to these clinics, they're trying to connect them back into their primary care office. These are for folks who may be having difficulty accessing those offices. And from a strategy standpoint, one of the reasons why the state is doing this is we're really trying to build infrastructure right now around offering a lot of vaccines, starting with the childhood vaccines, moving to flu, and then when COVID vaccine becomes available, be able to have these sites at the state that are out there. They have cold chain storage capabilities at those sites, as well as access to the immunization registry for impact. But we know that there are some communities that are not close to those offices, and the public health nurses have been setting up some additional community-based immunization clinics when they're requested. Another thing you've probably saw in the last 2 weeks is DHHS is really trying to encourage well visit appointments and getting kids caught up for all of their preventive services. Last week, they announced a $3.7 million in incentive payments from September to December to providers who are taking care of children enrolled in main care. It's an additional $31 if you are doing a primary care well visit with a vaccine, and an additional $37 if you're doing a primary care visit with an oral health screening and assessment and fluoride varnish. And you can get both payments if you're doing vaccines and oral health preventive services at those visits. We're hoping that these payments will help the providers reach out to families, provide services, and cover additional PPE costs. So that started a couple of days ago and will go through the end of December. Providers don't have to do any additional paperwork. It happens on the back end with the claims. Main Care is also allowing one additional health assessment per member within the next year. So if they had an additional appointment via telehealth, they can have an additional in-person visit paid for. So that's a new change as of March. They also have testing coverage for those who do not have health insurance. And CMS has said that providers can be reimbursed for counseling patients around the time of COVID-19 testing, around the importance of self-isolation, and you'll see the codes here that you could bill Main Care for. The other thing is the Office of Family Independence has streamlined some of their policies around eligibility for TANF, SNAP, and Katie Beckett, and you've probably seen the guidance around supporting school lunch and additional nutrition services through the school year. The federal government just put out last week, and they've extended that benefit. And then Dr. Carmack, who's the medical director of Office of Child Family Services, has been working with their teams around guidance for child care providers, child welfare, and behavioral health. I will say one of the things we hear back from the child care providers is sort of inconsistency in the medical community around returning kids to both child care and schools. Which is why Jen has gone through the chart as to what we are recommending in the guidance and really trying to make more consistency across the provider groups around return to school. It makes it easier for the daycares and schools if everyone is following a similar pathway. And I know that there's concerns about groups getting kind of overwhelmed with the number of notes that need to go back to school. But we are trying to provide some consistency out there for the different groups. In terms of communication tools, I just want to make people aware that the Maine Children's Cabinet youth videos are available, that you can use these short PSAs. They're generally a couple of minutes. We heard initially from a lot of the students that they didn't know how they fit into COVID. Why are they staying home? What could high schoolers do? So these videos have been made, and they're available for anyone to use with youth. DHHS also has a public awareness campaign called Keep It Maine, and they have posters in 7 different languages. They're available for download from their website. In terms of testing, I think this is probably the biggest topic we're hearing about in the last 2 weeks, and we are trying to work on it at the back end, as I know many of you are working on this at the practice and health system level, is how kids can get tested for COVID. There is a standing order at the state level that allows testing for kids 12 months and up that people can use. One of the issues is, where can they get tested? The state does have testing sites available. You'll see if you go to these 2 websites, they have the state-sponsored sites, and these are usually a low-cost, no-cost option. These are in addition to those that are sponsored by many of the health systems and many of your practices. One other issue that has come up is really the primary care providers have not been able to see the state lab results from HEDL, or many of these state-sponsored sites, they're all sending them to HEDL at this point. where their results are in. So now, as of August 12th, you should be able to see them in Health InfoNet lab results from across the state, and that should give you more visibility on positive tests. Another thing that is available, we've heard a lot from the providers around different types of tests, you know, what type of swabs, what kind of transport medium is needed for NP versus MP swabs. There is a chart from Hedl that's available. It's posted in this slideshow. It's also on the main AAP website, just for reference for folks. The big thing about the different types of swabs is more of how it's collected and making sure that you're getting a good sample versus the type of swab that is actually being used. So with a positive test, the Maine CDC does have a protocol with the schools. It's called the Standard Operating Procedure that was put out last week as a draft, and they're still tweaking it. But generally what happens with a positive test is there's a case investigator that calls the family or the positive case to interview them. They try to identify who their close contacts are. They make plans for them around community resources if they need additional assistance. And they connect them to the contact tracer, or you might hear the term enroller. The enroller, the other thing that a case investigator should be doing at this point is contacting the provider that ordered the test. What we're finding is because many people are using the standing order, their primary care provider is often not the person that is ordering the test. We've tried to close the loop on that in the school guidance to say that the school nurse will contact the primary care provider, but that is sort of an issue that we're still working through to make sure that the primary care person is notified. So with the Sarah Alert system, it's a web-based program. It's not a proximity tracker that you might hear about Apple or Google developing. You're really enrolling the contacts of the positive case into the system. They're checking them daily for symptom checks. They can use a text or a web link, an email, or a phone call to see if they're having symptoms that would flip them into being considered a case. If you are positive, you're not in Sarah Alert. It's available in multiple languages. I will say that what they're doing at the national level is trying to make it more health literate and put more pictures into the messaging. So they are going to include more languages, but right now they're trying to include more pictures right now. The other thing is the information does not stay in the database. It does get wiped clean of personal information 14 days after your case has been closed. So this is what Sarah Alert looks like in terms of the SMS text and the web link. They are looking for symptoms that are consistent with COVID-19. And there's been questions about what happens with those who are minors around Sarah Alert. For younger children or a minor, they set up reporting by proxy mechanism. They would go into Sarah Alert with the parent's demographic information, and they'd be talking with the parent. For older adolescents, they're working on a permission form from the parents to allow them to enroll the older adolescent in Sarah Alert and then correspond with the youth. So this is all happening in real time, so they're still working through the system. And I believe the last time I checked, there was about a little over 400 positive cases in children under the age of 20. It might be a little higher now, but there have been a fair number of children who have been positive COVID-19 in the state. The other piece is in terms of as we work on back to school and supporting the schools, the CDC has assigned a case investigator to be the primary contact to Emily Poland, who many of you know. She's the school nurse consultant at the Department of Education. I've seen in the chat box there's been some questions about if you want to develop a protocol around specific patient groups. Emily is the one that really should be your primary point of contact at the Department of Education. The Department of Education and the Maine CDC last week released draft standard operating procedures around case investigations in the school. I think if you go through that draft, you'll see how they are putting kids into cohorts. So if there's a positive case, is it the whole classroom that's going to need to go out or the whole school? And they're really trying to outline it in the guidance for folks. DHHS also has social isolation support program. So some of you may know Dr. Sharon McDonald. She is a medical epidemiologist. She works with a preventive medicine residency at Maine Medical Center, but she's also a consultant for the state on developing social isolation support for people who are COVID positive or suspected to be COVID positive, who may need additional assistance with food or housing or transportation to medical appointments, assistance that they might need to be able to stay in isolation. Otherwise, they might leave isolation and be more in contact with community members. Physicians, nurses, the schools can refer directly to COVID social support at maine.gov if they think someone needs social isolation support. And DHHS has contracts with the CAP agencies and community-based organizations to provide the support. It's both multicultural, multilingual, Catholic Charities, Opportunity Alliance, and there's 14 local community-based organizations. The state also has the federal funding to offer psychosocial support and mental health support, what they're calling the Strengthen Me project to the Office of Behavioral Health. It's really focused on psychological first aid, but really supporting different groups in the community. That includes both families, educators, as well as providers. And we've had since April a frontline warm line for providers to get free confidential peer support during COVID-19. And we would encourage you, if you would like assistance, to call or text this line. It is through 211, but it gets connected out to peer support. Generally, it's being staffed by psychiatrists through the Maine Association of Psychiatrists and different, we have also frontline providers from EMS and first responders and others who are taking the calls. So I think that is where my presentation ends. Thank you very much for allowing me to join you today. I know there's probably a fair number of questions, so we'll take those questions. And I'll just say, as part of the slides, there are references at the end. So I'll stop my screen share. Well, welcome back, Laura. So I think her internet dropped out. So welcome back, Laura. And I think the slides will be shared, and I think this presentation is being recorded as well. Laura, I think that there was a question for you around masking and recess and mask breaks. I think you're on mute, just so you know.
Because they've cut the internet to my house.
Okay.
I'm going to answer.
So another question, I think Laura's coming on through the phone, is the plan for All About Me messaging. Yep. So the All About Me messaging has been put out through social media through the Maine chapter of the AAP. I think the Department of Education has put it out. The Maine CDC through the Maine Immunizations Program has put it out. That information you could download from the AAP website and go forth and put it out widely. And okay, just looking through the questions.
I think there was a question about quarantine and why 14 days if you have a negative test. So I'd be happy to take a stab at that one. So that's really confusing for a lot of people, but basically the gist is if somebody is COVID positive, we know that the virus is viable based on lab studies. We can grow it from somebody's respiratory tract for up to 10 days after they develop symptoms. And so that's why if you are sick with COVID, but nobody's really been able to grow it after 10 days. So that's why if you're sick with COVID, your quarantine is for 10 days plus 24 hours. We also know that if you are exposed to COVID, you can develop symptoms up to 14 days after being exposed. Most people, it's 5 to 8 days that they'll turn PCR positive, but it can be up to 14. The reason we recommend, the CDC up until a week ago was recommending testing of asymptomatic contacts, is really to help more with defining whether somebody is a case. So that would change their quarantine. It would also change contact tracing. So, you know, if a child in a class was exposed and we found out really quickly that they were actually a case, even if they were asymptomatic, then it's a whole different set of folks that you have to contact trace. So, but the up to 14 days as of right now is because of that's the kind of the catch-all for when we think people can become symptomatic. So yeah, the quarantine for an exposed patient who's asymptomatic is longer than for a case.
And so there was another question around how many actually flip over from being a close contact to a positive. That is one of the things that they are tracking. So with the SARA alert system at the state level, they are trying to track and understand how many of those who are close contacts actually turn into a positive case. There's about a little over 2,000, maybe a little bit more in Alert right now in terms of contacts, and that is one of the things that they are studying right now. Laura, we may have you back. I don't know if you want to talk about the masking and recess, but you are on mute. In terms of, still can't hear Laura, addressing what exposure means. So I'll try to share my screen again. This is available if online, it's a link. This is the standard operating procedure that the Maine CDC and the Department of Education put out last week. I think it went out on the 26th to the superintendents, and then it went out, generally it was released last Friday. There's still a draft and it's being updated. As we learn information and, operationally as things are coming up, but this is currently where it is. And currently the definition is 6 feet and 15 minutes in terms of exposure. But if you go down through the chart, you'll see it kind of outlines isolation and quarantine, and it also has a chart around recommended public health actions for COVID-19 in schools in terms of number of cases, where the locations are, testing recommendations, quarantine. And so it's a fairly detailed document, so I would encourage those that are working with the schools and even everyone in the community to review it, to kind of understand the framework around what happens with a positive case in schools.
And Amy, I think we're also getting questions about what happens to the family of kids who are close contacts. While we're kind of on that subject, so basically if a child is not a case, but is a close contact, and they have to quarantine for 14 days, their family is technically contacts of contacts. So they technically don't have to quarantine. Obviously, if it's a young child, then there's going to be other issues as far as child care that play into things, but because obviously the kid can't go to daycare or have a babysitter or anything like that. But as far as actually having to quarantine the parents, unless the child becomes symptomatic or tests positive, then the parents and the family members are a contact of a contact.
Yep. According to SOP, Pat asked, close contacts at school are not advised to be tested until 5 to 7 days. Yes, that is the current recommendation. So unless they are symptomatic, they are waiting to 5 to 7 days to be tested. Another question is around right now, the Maine immunizations program is having people order 200 pediatric flu vaccines at a time. That is also correct. They actually have opened up their flu vaccine ordering a little bit early. Well, I think they opened it up a couple of weeks ago, but they're having people kind of order it in 200 dose batches because they want to kind of reduce waste, make sure that it all gets sent, and make sure that everyone has an opportunity to order it. But there is not, as far as we know, a shortage of pediatric flu vaccine. There should be enough flu vaccine. That's the guidance that we've been given so far, but people are encouraged to start giving flu vaccines in clinics. I think in terms of mask breaks, I'll just say generally, the schools are working out protocols around mask breaks, especially when they're outside at recess, they're more than 6 feet apart. I think mask breaks are important. Some kids will tolerate masks better than others. My own children were in summer camp all summer and had to wear masks, and they did fine. They're 8, but they're a little bit older. But I think that that's something that all the schools are going to need to work on, is making sure that there are some mask breaks available for kids and spaces where kids can go if they're having a hard time with masks, so that they can be physically distant and be able to remove their mask. And it's going to take some time. There is some guidance on desensitization that's on the AAP website. We've seen this from Pennsylvania's Autism Society, had a bunch of information. We know that there are some kids it's going to take some time. They're going to need to build up some tolerance to the mask, but it is an important concept. Okay, so in terms of comment on students and teachers who travel out of state, what's the appropriate quarantine or testing before returning to school? That is actually based on the executive order at the governor's level, at the state level. They need to follow what is in the current guidance that the state has put out around travel out of state. So if you're traveling to New Hampshire, Vermont, Connecticut, New Jersey, New York, you do not need to be tested. But if you're going to Rhode Island or Massachusetts, you would need to be tested and/or quarantined. And so that is based, that's not a school-based policy, that's really the executive order at the governor's level.
And Amy, as a follow-up to that question, is there any difference for kids who go for medical appointments, like some of our hem-onc patients who go down there for medical appointments?
There currently is not a difference if they're going to Massachusetts. I know that that question has come up fairly frequently. The last time they were visited, it was still that they needed to be tested or quarantined, but I know that that question continues to come up. There's a few questions around testing. I think testing is really the hot topic, Pat. I know, I see your question. I know you're on the back end working on this. The schools in general are having a little bit of a hard time securing PPE like N95 masks. So in terms of, are they able to secure testing and supplies? And that's something that's a much bigger discussion issue that we're looking at on the back end around testing for outbreaks. I don't have a lot of guidance today to say on the call, but it is something that's being looked at kind of more globally at the state level.
And then it looks like there's a question as well about, again, about kind of mask breaks and lunch and things like that, and what we are doing for kids who are 3 feet apart during lunch. And the recommendation is actually during lunch that they are 6 feet apart. So the recommendation for any time that their masks are off is that they're 6 feet apart. And we know that it's not going to be ideal. And, you know, again, it's that Swiss cheese model where we're doing the best we can with all of these interventions.
In terms of clear reasons not to wear a mask, there's not a lot of reasons we're suggesting that people should not wear a mask. Obviously, if someone has pretty significant developmental delays or reasons why they can't wear a mask, then what's happening at many of the schools are putting that into their IEP, and they're kind of working on desensitization techniques to work with them to kind of get to a point where they could wear a mask. I know that there are some children at the Back to School for the Deaf where they're using kind of the bottom sealed face shield and up to try to, they were having a hard time with some of the clear face masks that they had purchased for communication and lip reading. And so there are some communities that are trying some adaptations around this, but there's not that many that we've said you really can't wear a mask. So there are letters on the AAP website. There's some materials from different states that have been gathered from different providers. And there's also sort of a template that the chapter of the AAP has put together around masks. But in general, we are encouraging people to work towards wearing masks as much as possible. And if that's an issue, they generally will need to work with their both pediatrician and with the folks that work on their IEP with them. I think we're close to 10. I don't know, Mary, if you want to wrap this up. Or maybe it's just Jen and I. So thanks for joining Grand Rounds today. Make sure you hit in your code to get your CME credit. We do appreciate all the work that you're doing. We know things are constantly changing. There's always a lot of questions. We'll do our best to kind of work through all this with you. I think that there's not really a magic answer on a lot of this. A lot of this is we're just working through the systems, trying to figure out how to operationalize things, trying to keep kids and communities as safe as possible. So appreciate everyone's help on this and all the work many of you have done to develop these protocols and really to keep the work moving. So thank you, and we will talk to you all very soon.